Good afternoon, everyone. This is Kevin McGinnis, along with Gary Wingrove, bringing you the December 2020 edition of the Community Paramedicine Insights Forum, sponsored by the National Association of State EMS Officials, National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. We're pleased today to expand our offerings into the world of behavioral health and resources created for practitioners in the field, and obviously community paramedicine is square in that target area. We are pleased and privileged to have John Colburn and J.C. Adams from Cloud9 Telehealth with us today. Cloud9 is a technology firm that provides resources for telehealth for practitioners in the field, including EMS and our community paramedicine subspecialty. I would just note as an aside that as we have with only a couple of others in the past, we generally do not feature companies with a for-profit mission, but we certainly do feature companies that are cutting edge as far as some resources that appear to be valuable and worth considering in the community paramedicine endeavor. And this certainly falls square into that. However, we want to everybody to understand that this does not serve as an endorsement from any of the sponsors for Cloud9 Telehealth. Merely a great interest in hearing what they have to say. And to that end, I want to welcome Dr. John Colburn, who has worked in behavioral health for the last 30 years in many different roles. He's designed and evaluated programs to serve the seriously mentally ill and has specific interest in crisis intervention and access to services for individuals and their families. John is currently the clinical director for Cloud9 Telehealth and a consultant to health systems. His partner is J.C. Adams, who is a serial entrepreneur. That's S-E-R-I-A-L, not Kellogg's of Battle Creek, who's been launching startup companies his entire career in technology, marketing, and healthcare. He now applies business and technology experience to expand behavioral health access for those who need it most. Healthier Minds became his mission due to personal loss and lived experience helping friends and family. He launched Cloud9 in 2015, establishing the company's mission, designing the initial software product and market strategy, while assembling the team of industry experts capable of solving the challenges of behavioral healthcare transformation. As we all know, this is something that is of deep interest to those who are leading CP efforts. The more successful we seem to become in our endeavors in our communities, the more often we seem to get caught by folks in the behavioral health segment of our healthcare community saying, "Can you come over and help us now?" We have answers out in the field and homes, among the homeless, among a variety of folks that we just simply don't have the mobile resources to deal with. And the more that we get asked to get involved in that, the more we need resources to help do it successfully. And that's the purpose of today, is to explore one of those resources. So without further ado, I want to turn it over to Dr. John Colburn and J.C. Adams.
Okay, John, I'll kick us off and get us started. And first off, thank you so much, Kevin and Gary and CPIF, for having us today. And thank you all for joining, especially this close to the holidays, and as well amid a serious spike in COVID cases around the country. We really appreciate you joining. And part of our presentation today will be about some of the innovations in technology that we've been
share your screen, JC.
Developing here. So yes, I will share this screen. Is that visible for everyone?
Yeah, you got to go full screen.
Here we go. There you go. Can everyone see full screen now?
Perfect. Yes, indeed.
All right. So, yes, we want to share some of these ways that we've been applying technology, particularly data and telehealth, to address these growing behavioral health issues that were mentioned earlier. And our belief, though, is that this technology is not ultimately the solution. It's people that are the solution. And everything that we're building on the tech side is merely to support people who are out there, especially on the front lines, trying to help other people. And that's our mission, is to just listen and learn as to how we can better design solutions. So again, this webinar is intended for mutual learning. We want to share our stories, statistics, and hopefully some of these ideas will stimulate some questions and comments at the end. And obviously, you all care about this subject in your communities. You'll probably quickly realize when my colleague John Colmer and I are speaking, community paramedicine is not exactly our area of expertise. However, we clearly recognize its value, as does the rest of our team, and we absolutely want to support every way we can in developing solutions that can be beneficial for you all. So we're excited to learn more about that during the Q&A. Each of your communities is also unique, with unique problems and unique approaches to solving. So yes, please do chime in later and let us know what's going on in your community and how we can learn from one another to help make improvements. So let's see. Thank you for that warm intro. There's the rest of our team here that you can find online, and a lot of decades of experience in healthcare and technology, as well as public safety, and we're all really dedicated to public health innovation and social justice. And as a mission, we started the company to increase healthcare access for underserved populations, but as we spoke with public health entities and public safety officials even, we learned that really the focus that they wanted us to take initially is on behavioral healthcare access for individuals that are often referred to as high utilizers, that can have a combination of issues, including physical illnesses that are combined with mental illness and, in many cases, substance use disorder. And a lot of these individuals are caught in this failed cycle of non-treatment and readmission that you all are probably very familiar with, this revolving door of individuals being taken to emergency rooms, jails, tying up the court system. There's a lot of evidence showing that individuals that do get tied up in criminal justice come out worse. And that is, adding to issues around the country, including our growing homeless crisis. So we build these solutions for community mental health centers, as well as these are designed for cities and counties. And John, I'll turn it over to you here to start to highlight some of the initial problems that we want to address for this segment.
Well, thank you, JC, and hello, everyone. It's a real pleasure for me to be able to talk with you today. As Kevin was saying in the introduction, I'm a psychologist. I've been working in the field for actually over 30 years, and I've just been working with Cloud9 for about 3 years, and we kind of feel like we're in the right place at the right time, in that the growing need for technology approaches to helping people get access to care has never been greater than during this pandemic, although it's always been fairly good and great in terms of need. But the kinds of problems that our healthcare systems, our agencies are dealing with, in my view, just seem to right now be in a real cycle, upward or downward, depending on how you look at statistics and whether you view the glass as half full or half empty. But one of the problems that I know many of the community paramedicine programs around the country are particularly focused on is being that connection between the health system and patients who are prone to, if not frequent, at least often enough admissions to hospitals due to either their medical condition or their behavioral health, or a combination. But some of the kind of startling data that I saw as I was preparing for today was how, the fact that 20% of Medicare patients are discharged from the hospital get readmitted within just 30 days. And, of all Medicare patients that get readmitted, it seems like a small number, but it actually accounts for a lot of folks and a lot of cost. 13% of Medicare readmissions could have been prevented, and there's a litany of information available on how to prevent readmissions, and you folks, I believe, are at the cutting edge in that by being able to reach out to folks in your community, identifying maybe by referral from the local health system, people who are on the way home or are at home who need someone to touch base with them, review their discharge planning information, review all their transition of care data, as well as teaching that can be done, as well as knowing how those folks can stay connected to healthcare. Because depending on the condition, one can easily relapse if one is seriously mentally ill or has substance use, or if one has fairly serious medical conditions like congestive heart failure, eating the wrong thing, drinking too much water, and you're back in the hospital if there isn't someone monitoring your care. So we've figured out some ways to just support you. As JC was saying, you're the folks that are doing the work. We wanted to create tools that can absolutely support you, make the work more efficient, and in the long run, actually more effective because you can reach and touch more folks. So let's take a look how we do that in the next slide. So Cloud9, as you've seen, is a tool. It's an information systems tool. It's an application whose basis is built on servers that are in what's called the cloud. It's not the real cloud, it's the data cloud, where good information can securely be provided and protected. And what our architecture allows for is different parts of the healthcare team. It could be primary healthcare, it could be you all in EMS and community paramedicine, should be able to both communicate directly with the consumer out there in the community that you're providing ongoing transition of care services to, but also in our system, we want you to be able to connect to colleagues who are working with the same individuals so that you can coordinate services or you can get consultation. I know a lot of EMS programs are part of that new CMS pilot, the ET3, Emergency Triage, Treat, and Transport, where the idea is to create incentives and systems that allow folks who don't need to be transported to an ER can be instead either treated directly in the field or can be transported to, let's say, an urgent care or primary care office. We've designed our system to be able to allow that to actually happen for you all in the field who are first responders or community paramedicine to do consults with your team. It could be the emergency room physician who you partner with to do initial assessments and determinations of what should happen, or to the ongoing care, perhaps the geriatrician, perhaps psychiatry or mental health clinicians who can work with you and the patient simultaneously. They can visualize and speak with and assess the consumer directly, and you can as well if you're doing ongoing care. And we're going to talk about that in the next slide. But the important part, don't go back to that one for just a second, JC, I'm sorry. The dotted orange lines that you see, that represents not only communication, voice and video between all these different parties, but it also includes data. In other words, we can create our app in such a way that we can connect important data from electronic health records or other data systems to a series of integrations where just the information that the stakeholders feel should be shared over the app is shared. And each one of these entities in the healthcare team has specific permissions to access that data. So if one is, the healthcare provider, they get access to all the medical information and perhaps some of the behavioral health. The other thing we do to anticipate your probable question is we can engage, or you can engage the consumers, the patients, in a process in which they provide consent, either over the app or through other means that allows you all to collaborate to serve them. Okay, now we can go to the next slide. So one of the basic versions of the Cloud9 app is what we refer to as prevention. And it's like a closed loop. It allows practitioner, provider, community paramedicine individual to talk and visualize their clients. Over the app, what the users see is a list of, if you're one of the CP folks, you can see a list of your current enrolled consumer patients. You can click on one of those, and if the person is available, they will respond, or you'll see their face. You'll be able to talk with them. In the same way, over the app, you can send text messaging to that individual. And you can also push out any kind of prepared information you have, like a list of reminders for folks with type 2 diabetes. If you're working with a person who has been dealing with one of the more common mental health conditions, as is illustrated in this slide, you could send out global assessment and diagnosis of anxiety, the GAD-7, that the person can actually respond to on their device, complete that survey in just 2 or 3 minutes. The results immediately are transmitted back to the clinician who's working with the person, and it's also displayed in something we refer to as track in the app that allows both you and the consumer patient to see how they've been doing over time. The app can be programmed if it's desired to remind folks or to demonstrate to folks how well they're doing, or perhaps they need additional support since maybe their anxiety is now going up, and that's visible to both the clinician and the patient. Okay, Jason. So one of the best uses, and this is the one we're really wanting to share with you today for this prevention app, is imagine a person is in hospital and they're about to go home, and as part of their discharge education, someone at the hospital is able to provide them a device as well, unless they have their own, and they can put our app on that device and show the person how to use it, actually connect them to your department, one of your community paramedicine folks, who can introduce themselves and practice communicating over the app with this person. Then the person is discharged, let's say a day later, and you can actually on the app schedule a video voice session with that person. You can send text messages reminding them that they can use this app and that you're available for ongoing support, which can be provided both over the app, or if your system requires you to make at least one face-to-face encounter, you can do that, practice using the app with the individual. And in this way, we believe you are removing a lot of barriers that many patients have after they've been discharged, particularly in those communities where folks, and this is often true in behavioral health, are asked to go to their next appointment in the outpatient facility. And then that person has to find transportation, has to find the money to pay for transportation. Maybe they're in some type of work where they need to get off, and that's a hassle, or they have children, or they have other barriers, including just maybe not being as motivated and not wanting to have to take all the energy to get there, and so they don't show up. So colleagues of mine that have been working in community mental health centers, in terms of their face-to-face appointments, they complain that anywhere from 30 to 60% of their scheduled appointments never show up and don't call to cancel. It's an issue of concern because people need ongoing care. So that's part of the reason we created this app. Folks can be taught how to use this. They can connect when they want to, when they feel the need. They don't have to wait for that scheduled appointment. They can open the app. They can see who at the agency they're working with is currently available. All they have to do is click one button, and they're connected. In the same way, folks in community paramedicine or perhaps partners at the Community Mental Health Center or FQHC have the app and connects to people by first sending a message or just trying to connect directly. What we know is that this does reduce hospital readmissions. People who get frequent and consistent care in the days following discharge from hospital, whether that be for mental health or medical issues, will be rehospitalized, particularly within 30 days or less often. One of the other advantages of having this connectivity is that, particularly in today's world, agencies can bill Medicaid and Medicare for telehealth visits, and in particular, Medicare has, renewed and extended payment for transitional care treatment, case management, and visits. That all can be provided over our app. So we can go from there. Now, other workflows that we've created on this app that are used with that prevention are ways to, number one, starting on the left, this would be for one of our colleagues in community paramedicine or perhaps a behavioral health clinician to see who their current enrolled patients are. And you can click on them, you can look up their history, whatever history is available. In this workflow, we're showing that we can either through an integration to a health record or by adding the information that could be added either through self-report by the patient or perhaps a caretaker for the patient, their current vital statistics, vital clinical markers. We can also add information regarding their social determinants of health. What's their housing situation? Do they need assistance with feeding and food? And do they have issues and opportunities to be connected to financial supports either through public programs like Medicaid or other programs that are available, particularly hopefully in the next couple of weeks through the newly passed bill to support folks who are needing support as a result of the pandemic. And then finally, the app can show the providers who are available and who are available to collaborate with you and also perhaps jointly to collaborate with the consumer. Okay. JC. So what we did is we deployed our prevention app within a community mental health center, and several consumers of the agency who were diagnosed with mental illness and who were categorized by the local state system as being affected by serious mental illness, but who were living in the community, were encouraged to participate in this pilot that we did. About 31 individuals did participate. What we found were that probably half of those individuals did not have adequate smartphones or data on those phones to participate, but we, through a partnership with Verizon, were able to provide them with devices and with enough data to always be able to connect when they needed to, or when we, our clinicians, through our partner, wanted to connect. These folks, prior to the pilot, were contacting the agency about once every 90 days, which was not adequate. They were ending up in hospital or in other crisis scenes. Through the availability of an app to connect to their assigned clinician, they were able to increase that engagement about 68%. In fact, they were being seen either on the app or in person once every 15 days during the time we did this, which was over 3 months. We had an external group doing the evaluation. They spoke to everyone who used the app, either the patient or the provider, and we had no one refuse to talk about their experience, and 95% of these folks said they would recommend the use of the app for patients and their providers. And 100% of the folks we asked to participate actually completed video appointments and had positive outcomes in that they attended ongoing, and among this group, and it was a small group, but what we were doing is demonstrating that the whole solution can work in this setting. 100% had positive outcomes, and those were simply defined as satisfaction with the program and not being moved up to a higher level of care, such as either a very intensive outpatient program or a hospital. Okay. So, JC, did you want me to continue from here, or do you want to take over now?
I'll maybe run through a clinical workflow for intervention, and then I'll pick up right after that. Okay.
All right. So another version of our app we refer to as Cloud9 and this is a specific workflow that we created to help individuals who are out in the community who themselves or their folks that are around call 911 because they're concerned about what's happening with them. And this is particularly in the context of folks suffering from a mental health crisis or condition. And what we wanted to be able to do is connect whoever the first responder is on these crisis calls. That in many communities is EMS, and many other communities it's the local police or county deputy sheriff team. And another way of dealing with this that you've probably seen or have in your community is the whole idea of a ride-along or a co-responder. In some communities, I'll just keep talking about co-responders, JC. In some communities, actual clinicians ride with the deputy or police officers in the squad car during an entire shift. And if they come across a mental health crisis, the behavioral health clinician is there to manage the situation along with the officer and get that person sent to the proper care. Our alternative to that was to, instead of having one individual in one squad car and maybe get connected to a mental health crisis, we connect the officer over our app to a mental health clinician who is available to take calls throughout their entire shift from multiple officers, because multiple officers have the app loaded perhaps on an iPad in their car. Over the app, there's data about those individuals in the community who are frequent utilizers of the system. And what we know from our colleagues out there in first response is about 50% of the mental health crises they are called to are people that are known to either the mental health system or to all the helpers that are out there. You know, we've heard of clients who call 911 once a day, 3 times a week, because they're scared or they're paranoid or they're just lonely. And by regulation, someone has to respond. They come out and they realize that, no, this person needs less of a level of care than being taken to an ER. So there's all kinds of information that the officer or the other first responder can see based on past history. If the person is new to the system, there's a way over the app to create a very brief profile of who this individual is. Based on whatever history is available, the officer is able to determine a kind of a base level of risk that can help in terms of either immediately taking the person to an ER, or in about 80% of the cases we're aware of, they can connect over the app, just like in the prevention app, to a mental health clinician who is sitting there on call. Their name is on the officer's list of available providers. All the officer does is click once in their live voice video with the clinician. The officer can explain the situation and actually ask the person there, the patient, the consumer, to whether or not they would like to speak to a professional mental health person who can help them figure out how to get through this current time and get ongoing care. In the pilots we've done with this and the other deployments, we've seen around a 99% acceptance of that offer. So it's very rare that an individual, I mean extremely rare, that someone would not participate. They get the help they need. clinicians are able to do an assessment within 15 minutes, can work with the officer to take the person to wherever they need to go. And in the next slide, we see many options for where they could go. I'll just give you a very quick clinical scenario that is really representative of what we see. Let's say the person, this is based on a combination of many situations I've been involved in. But Joe is a 38-year-old man who has just moved to the area within the last 6 months. When he arrived, he tells the officer that he thought he had a job, but that didn't work out. He didn't know anyone in town. He ended up living in a shelter. And as time passed, he became more and more anxious and concerned. He admitted that in the past he'd been treated for behavioral health condition of anxiety that had been successful to the point where he had been able to work in his previous community, but thought that he could have a better life in this one that he moved to. So he was very, very agitated, very concerned, and it was to the point where people around him at the shelter were concerned, and they had called 911 because Joe was kind of mumbling and he seemed a little incoherent. They didn't know quite what to do. The officer came out. They realized that they did not have any information about Joe, and they were able to create a profile, and at the same time they connected to a mental health clinician who is local and who works for the community agency, the mental health center, and was able, within 15 minutes, to come up with a plan with Joe, which was, number one, Joe was able to tell the individual that in the past they had been on medication. The person at the agency was able to connect to a psychiatric nurse practitioner who was able to participate in the assessment and was then able to prescribe medication at a pharmacy that was within blocks of where Joe and the officer were. They were able to arrange for the agency's mental health crisis outreach team to come visit Joe later in the day, and at that visit they were going to be able to put Joe on the app for prevention and let him connect directly to one of the case managers who would be able to work with him until he felt stable and had a place to live and work. So he was able then to return to the shelter. The crisis team came out to see him 4 hours later, and he got engaged in care. And because he didn't have to deal with transportation and financing that, he was able to work with case managers at the agency over the app, and they were able to refer him to local social services who helped him get connected to resources in the community that helped him find both some employment and housing. And he's now discharged from treatment and doing well. And that's his story. So what happened is the responder arrived, and because they were able to use the app, see the data that was there or not, talk to the person with the clinician, get them medication, get them services later in the day, you know, that cycle of being seen by responders, having to take them to an emergency room or jail, and then being not treated in those settings properly and then sent back out. That cycle was broken for this individual, and we believe for a good majority of the folks that we help through the app, through your work as EMS providers. And, you know, when people do need ongoing care, that care could be provided over the app using your community paramedicine team, which could provide a combination of face-to-face and app-based care. Thank you, JC.
Thank you, John. So everyone, I think you can see there's many clinical success metrics that we can achieve improving outcomes for behavioral health patients, whether they're in crisis or if we're using this tool to help, let's say, community health clinics and mental health centers provide ongoing care and prevent those crises from ever happening in the first place. But since collaboration is across care teams is part of our solution, that's not always an easy thing to get together for many cities and counties out there to get cross-agency cooperation. Some communities have made a lot of progress in doing so, getting that coordination. Others are just getting started or haven't really even started moving in that direction when you get into more rural areas of the country. But, that's not an easy thing to do. And then also, we need to get often cities and counties to participate in launching something like this from a cost perspective. So that can be difficult. So in addition to these clinical success metrics that John was speaking to, we have to sometimes find a way to incentivize communities to take action and adopt innovations like this for data and communication. And the best way to do that is to show also the economic success metrics in addition to the clinical success metrics. So just to give you an example of efficiency, this is a slide we borrowed from one of our pilot launches with Harris County, and this is a quote from the sheriff's office there, where they were using this. Instead of having one co-responder riding around in one law enforcement cruiser, or this could also be a co-responder program deployed in other means, but you have one clinician showing up to the scene of one crisis. Here's the scalability we have in Houston and Harris County. We now have 9 master's level clinicians, whether they're ride-along or staffed at a call center. They're now serving 100 first responders out there with on-demand access to these clinicians. And that is a huge force multiplier of scalability. So initially when we launched this here's some data gathered by University of Texas Health Science Center, where we compared the co-responder model to the remote clinician model. And in this case, through a lot of different metrics, they determined that 97% of Cloud9 consults were superior or equal to having the clinician physically there at the scene. And there's a lot of reasons for that. And that scalability initially, when we launched this, showed a 632% return on investment economically for the county. So it's just much more affordable than the physical co-responder model. And we showed a decrease, an initial 22% decrease in mental health crises landing in ERs and jails. So that's also a human impact number, where we're keeping individuals out of setting they don't belong. You're not always getting the best care there. So that was a benefit for the consumer, but also the cost savings. In our state, where we're based, it's calculated that $2.7 billion are wasted each year when a mental crisis lands in ERs, jails, and courts. And that's just those 3 line items. That doesn't take into account first responder time, vehicles, resources, and a lot of other costs that are added up with that inefficient system. So by diverting at Intercept 1, we can definitely make an impact, and these are some of the ways that we're seeing this take off now as a superior solution. And again, it's not just that intervention, as you see here on the right. Not every individual that is out there that needs behavioral health care services, those ongoing services, it's not like not all of them are going to have such a bad day that 911 gets called, they enter a crisis, that they encounter your teams out there in the streets or law enforcement. And they don't need the intervention tool, Cloud 911, but certainly every individual that is in a crisis that encounters our system, we do want to immediately refer them back as quickly as possible to the prevention app, get that downloaded on their phone, on their personal cell phone. If for some reason they're a low-income individual that qualifies for a health phone program, will help facilitate that. And as John had described earlier, get that continuity of care for individuals after a crisis or after a hospital or jail release. Get them into that prevention model with that application so they're always connected to services at all times. And here you can see this is what it looks like in real life. This is how patients actually use the prevention workflow. From anywhere, anytime, you should be able to access case management, prescribers like your psychiatrist or a nurse practitioner, peer support, recovery specialists. You should be able to do that anywhere. And on the right, let's say it is a crisis, we should make sure that all first responders have mental health care, behavioral health support, clinical staff, data, and information. And what you see here, this is a behavioral health session being conducted by a remote clinician on the tailgate of a pickup truck. Now, it can be in the back of an ambulance. It can be on a park bench, if it's a homeless person, wherever out in the community. But most of our encounters thus far have been in residences. So, but again, we want to make this available anytime, anywhere. So I'll wrap up there, and we hope that today we shared some information that may have sparked some ideas or some questions that we can answer. So I'll pause there and open it up for the Q&A section.
Super, gentlemen. Thank you very much for your presentation. That was very interesting, and I think an approach that that folks in the community paramedicine world could see as being beneficial. Let me start with a couple of questions just to get things going. It sounds like Cloud9 provides a kind of bridge among pieces that need to come together either in the prevention segment or in an intervention segment. And the pieces, what I'm interested in knowing, I guess, is the pieces that somebody who leads a CP program needs to think about putting together to be bridged to. And one of them you mentioned certainly is having a telephone, having a smartphone, cell phone for patients to utilize to do the remote communication that needs to be done. But the other is the actual behavioral health professional resources to get on the line in an intervention phase. And I think that in some settings like Houston, Harris County, you have, we're familiar with Project Ethan. You had mentioned that you were familiar with that as well. You have a setting in which they're able to put doctors on one end of a telehealth, emergency docs on the one end of a telehealth line 24/7 for paramedics and the Houston Fire Department to do telehealth to hopefully keep people from going to the emergency department unnecessarily. And presumably in Houston, Harris County, those kinds of mental health resources would be available as well in some fashion. If I'm a community paramedicine leader in my ambulance service that's 30 miles away from the nearest hospital, doesn't have any native mental health resources in town at the moment, and now we're being asked to create that capability. Where do I go for that? Does Cloud9 provide assistance in planning to connect with mental health resources? Do you provide it on a distance basis, or how does that work?
We have a couple of ways that we can help facilitate this within the community. And our general belief is that the public safety net, community mental health centers around the country should be our number one go-to resource. So in urban areas, they typically serve one county. In a lot of states across the country, they'll serve, if you're in a rural area, it'll be one community mental health center covering a group of counties in a larger geographic area. But sometimes they're under-resourced and don't always have enough clinicians to serve the needs. So we do have a second option to bring in an additional remote clinical care team that can be made available. But John's experience in managed care and building networks, John can explain and elaborate on that a bit more about how that would apply to, let's say, a community paramedicine leader in that scenario. John, any additional thoughts on that?
Well, yeah, as JC was saying, folks, because local resources are, in our mind, often the best because they know both many of the patients that are going to be calling in, and they certainly know the geography and what the other safety net resources are. But in those communities like you were asking about, where you're 30 miles from the nearest hospital and you have no local mental health, we have the partners that we can work with that can provide distance from distance combinations of psychiatry, advanced practice psychiatric nurses, and mental health clinicians. And we link our customers up in the communities to our partners who have these nationwide networks of professionals, and we help create workflows to incorporate our partners who are in these pre-designed networks for behavioral health to make their teams available in the numbers and at the hours that are most needed by our customers in the field. And of course, we do, during implementation, ensure that those folks are very familiar with both the culture and the geography of the community they're serving. But these are folks that are well-trained, well-experienced in terms of doing telehealth interventions with mental health crises and people who are somewhat fragile and know what next steps need to happen in terms of ensuring ongoing care, whether that's through that provider partner of ours or through referral to local resources.
Yes, and one final thing on that would be there are growing resources to support these. So if there's ever a concern that, okay, our community health clinics or local mental health authorities, if you think that they don't have the funding for things like this or not enough clinicians, we're seeing more and more resources being made available to communities, including grants that can be applied for to pay for clinicians that we can help staff. So I'll just stop here.
Well, I think that's going to be important, just to underscore in our world, in community paramedicine, where we have no single or even small group of sources for reimbursement for anything we do. The ET3 program that you mentioned is breaking the ice for CMS to actually recognize community paramedics or EMS as people that ought to be getting paid for other than transporting people to the hospital. There are some other limited programs, and they're multiplying. It is getting better, no question, for reimbursing community paramedics for what they do, but we're still not there yet. So that's an issue for us. And so, I mean, if we're going to get involved with this, that's certainly going to be on our minds. You mentioned the Verizon assistance for phones. What is that? How does that work?
Oh, in the past, we've that's just been one example of a telecom provider that we've worked with that's partnered with the community to set up a relatively affordable program with government pricing. But it's not just limited to one telecom provider like Verizon. But that's an example of one that we've had success with in the past. And what we can do is get this basically what we call a help phone. And we can even do this with a newer phone or refurbished phone, but it's basically locked down you give it to the consumer, and it's locked down with something called mobile device management software. So it's not a phone that you could use for outbound calls or watching YouTube videos. It's really limited to the healthcare apps that are on it, as well as other healthy behaviors and social services. So you would have access to Cloud9, for instance, if you're dealing with another medical condition or anything specific. We can have additional health apps on the phone that we call digital therapeutics. Also, you can connect back to social services, housing, food, childcare, financial, employment services, et cetera, on the device. You can connect to the public library. If it's someone that's coming out of the criminal justice system, you can connect back to your parole probation officer, the judges, et cetera. But it's not something that you're using for other purposes. And also, it's managed really tightly, so you can't hawk it, give it away very easily. It would say this is the property of XYZ County, and we would remotely wipe all the data. If we couldn't contact the individual that's supposed to have the phone, it's supposed to be in the possession of the patient we issue it to. So that's kind of how it works. Pricing is anywhere, we've given out relatively new iPhones for $40 per patient per month. It can come down to $20 per patient per month for a older Android device, and that's kind of how it works. And we can do that with a variety of telecom providers.
Interesting. Thank you.
Yeah. Mm-hmm.
Gary, do you want to open up the line? I'm sorry, go ahead.
No, I was going to ask that because I would love to hear feedback from people, what their other questions are, just what their first impression is after hearing this. Is it totally wacky, or is it worth considering?
The conference has been unmuted.
Okay, all lines are open. Let the gentleman hear your reactions to their presentation, and if you have any questions, by all means, ask them. Well, let me break the ice one more time. My first impression is I think this has great potential. I think that it's going to require some planning. I think this provides a resource that would be of great use, especially in the setting that I described, which would be a smaller community that might not have the mental health resources that you were talking about, to be able to fall back on that, on those professionals in particularly intervention scenarios. I think that it's going to clearly require a community paramedicine team to work with a mental health professional to design the program, to learn how to use the resources, that is, make decisions such as in the prevention mode, using that general assessment tool that you showed early on. Is that something that a community paramedic could be looking at, administering and following on an ongoing basis, and then connecting with the mental health professional, medical director periodically to consult on that patient? They're going to have to make decisions about what the protocols for all of that are.
That's all something that I would work with the community on. I spent my 30-plus years in mental health. I spent about 8 years in the community running a community mental health center, and being, I think I was one of the first people that actually rode along in a squad car to help work with people who were having mental health crises. This was 1978.
Oh.
We didn't have cell phones. We didn't have anything, so we just had to go out there, and it was a rural area, and we had some interesting cases that we worked on that required a lot of negotiating and delicate management of situations, in which the police officer sometimes had to be front and center, and other times would graciously step back and let one of my team, spend time with the individual and just try to develop some trust.
understand. Well, it's interesting. In EMS, there are a number of models evolving for managing and intervention needs as well as prevention needs that have created different types of teams. And there's been a law enforcement officer, a social worker, a community paramedic, or an EMT going in team fashion as needed. Mm-hmm. And I think as we're trying to get our hands around what's the best way to do that, and it may be different from community to community, this kind of tool may be very handy.
Yes, and the required planning is something that I think we're seeing a lot of help coming down the pipeline. You're right, it requires planning, and with even mid-sized communities, we see them putting in place a county employee that is a behavioral health director. And their job is to kind of have that global view of the county's needs. And that's not coming from the community mental health center. It's not coming from law enforcement. It's not coming from just EMS. It's kind of that larger, higher level perspective. And it's becoming their new job description to provide a lot of that overall planning. And the way we look at this, the issue of not meeting the behavioral health care needs of our communities kind of started decades ago, and it's kind of landed on the laps as a problem for cities and counties, and now they're in charge of solving this in many ways. So we look at the county as the main initial source of stakeholders where we go to find out who all the community stakeholders are, what their needs are, and get the funding and that guidance and planning that you're talking about. So when we think about community paramedicine and EMS, in many cases, we're just asking you all, how would this benefit what you're doing, and how you can coordinate with your community, whether it's a county behavioral health director or other stakeholders in solving the greater issues for the community. If that makes sense, that's kind of how we're looking at it. And we just want to address your needs as a particular user of a tool like this, not necessarily someone that your agencies need to pay for it, nor make a lot of overall planning decisions. We want to make it easy for you all.
Sure. Well, I think I'm aware of a number of potential use cases out there that I can share with you offline I'd be really interested to see what their impression of your service would be. So we can do that. But in the meantime, do we have anybody on the line that would like to ask a question or make a comment?
Hi, my name is Amy Eisenhower, and I'm the EMS for Children representative for the state of New York.
Hi.
Hi. Have you done any work with psychiatric problems with children, particularly with schools being closed and COVID happening, and a lot of the kids in rural areas don't have access to services they normally would?
I'm sorry, who is this?
Amy Eisenhower. I'm the EMS for Children coordinator for the state of New York.
Okay. We haven't. Some of the EMS agencies with large pediatric populations might have. I wish I could give you. Have you tried some of the children's hospitals? Where are you in New York?
I work for the state. So
for the state.
I'm sorry. Excuse me. Who's speaking?
Okay.
I heard Amy, and who's been responding to Amy? Hello? Kevin, are you there?
I'm sorry, gentlemen. I don't know who that was.
Oh, okay. Well, let me respond then to your question, Amy.
Sure.
Similarly to whoever that good person was, Cloud9 hasn't been directly involved with the pediatric population. We view, however, our solutions and technology to be compatible with meeting those kinds of needs. The issue would be to connect the right type of supports meaning pediatric behavioral health professionals, to the family. Because of the nature of the app, it can allow an entire family to speak to a professional. We could sequence a parent speaking with a professional, telling what the concerns are. That family could provide, if they choose to, privacy for the young person if they're of an age that they should have some privacy, to connect to the professional and provide all the usual kinds of therapeutic interaction as well as assessment interaction that behavioral health professionals provide for children and youth. It could all be done over the platform. We are interested in finding opportunities to work with programs like that, and we particularly think it is relevant to folks who are in more distant or rural areas, and think it can be effective, and certainly it can be reimbursed now under both New York and other states' Medicaid programs.
Okay, thank you.
Thank you.
Thanks for the question. Anybody else out there with a question or comment? Sounds like we're going into holiday mode. People are lower energy.
Yes. Well, look, if we have our contact information displayed here, or you can reach out to the group and get it if you need it at any time. We are always happy to take questions offline and follow up with those additional use cases you just mentioned that we could potentially look at.
Well, that's great. I'd be glad to talk with you about those. I think that would be fun.
Great.
Okay. Well, listen, John Colburn, J.C. Adams, Cloud9 Telehealth. Thank you for bringing it to us and letting us know a bit about a potential tool we may be using in the future. Very much appreciate your time and your help with this.
Thank you.
We appreciate.
So much.
Yes, we appreciate you all and the work you do. Thank you all, and have a very happy and safe holidays.
To you as well.
Thank you.
This will be the end of our 2020 series. We will be starting again with Community Paramedicine Insights Forum in March. And just want to remind you that if you want to put them on your calendar for the year of 2021, it is on the third Monday of the month at 3 p.m. Eastern Time. And we ask you to reserve an hour and a half for them. Sometimes go that long, sometimes we don't. But on behalf of the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, the Center for Leadership, Innovation, and Research in EMS, my partner Gary Wingrove from the Mayo Clinic, I want to wish you all happy holidays, and I hope it's a less exciting year next year. Take care, everybody.
Thank you. Thank you.